that's my name and where I work. That's a brand new building over there. It's real nice. And this is my crew. It's an addicted group of people to work, and they're really a fun crew to work with. And this is my place. These are some of my calves that were hiding last week. You can see them all hiding in the tall grass. You may not think of Texas as being full of tall grass and having too much rain, but you can see a little puddle there in the levee. We had a lot of rain last weekend. I have originally told you I was going to talk about controversies, and I think we had too many lectures yesterday. And I know we had too many lectures for me. And I think we can go a little high octane today with just case examples. And so I picked some case examples that would be a little bit unusual. These are sort of like uncommon presentations of not so uncommon problems. We talked about impaction yesterday, so I thought I'd talk about one of those. We talked about some obstructing bone fragments yesterday. We talked a little bit about non-union, but we didn't get too much into it, but we kind of hinted about ramus non-union and what to do. And then I just thought it would be a good idea to see that sometimes we got to step a little bit out of our lane, but not too far out of our lane. So let's just start with this, and we'll be interactive. And Connor's going to help me tell who to ask, and Reza is going to tell me who to ask. And so Reza, who should I ask about interpreting this film? Tell me the name. Good morning. Say it again. Nice to see you. And so we're gonna pass the mic so that people on the Zoom. I guess we're on. Are we on the Zoom? Yeah. We're going to have the people on the Zoom hear you, and so everyone is anxious for you to tell us. And you can choose an injury. You have several injuries to choose from, and you can take the one you want.
So this is
It's pretty bad, isn't it? It looks terrible. Yeah. It's in a bunch of pieces. Yeah. What else? What else you got? Look over here. Yeah, he's got displaced left acetabular fractures, and you can see if you look, the ilio is disrupted. And so the ilioischial is disrupted, and the iliopectineal is disrupted. And so we have disruption of the ilio at both sites. And so that's going to sort of trigger us into, 5 potential fracture classifications. What could that be? Will we disrupt the 2 lines? 1 elementary, 4 associated. You want to call consult?
Sure.
All right, here we go.
So transfers.
So the elementary transfer for sure involves the 2 columns, correct?
One would be T type.
D type, I'll give you that.
One would be intercolumn.
Correct. Intercolumn posterior transverse involves the 2 line. You're doing great. Associated both column for sure, and the one everybody forgets. Or it should have thought of first. If you just built off the transverse, it's not. Transverse associated posterior wall. It's one everybody forgets. They always forget. But if you just go right from the transverse over the transverse posterior wall, you'll always get it. Anyway, that's sort of what we're working with. Super. And you can see it's got it's not congruent. So the joint is out around. We can look at these surface renderings real quickly and see that the anterior column area is split right in half by that fracture that goes right through the psoas gutter, a real common fracture plane. The pelvis has tectonic plates as well, just like California has pelvic areas where earthquakes happen reliably. The pelvis does too. This is a really reliable place where a fracture plane goes through, and we can even see the plane of the fracture by just turning it. If we wanted to see and clean that fracture, that's what we'd have to look at to see it. And if we were going to put a clamp on it, we'd have to do a little more cleaning medially, wouldn't we? You can also turn the patient into an iliac oblique for a surface rendering and see and we can also see this femur. This femur's looking bad, isn't it? Pretty terrible. Dr. Dunbar, how you feeling if you're on call with a femur like that? You good?
Ready to go.
Okay. Well, I'm gonna ask you to make some comments here in a minute, because ready to go is what I like. Then we can turn around. We don't always look at this view, but it's a good view. We can see the ischial spine is split, and the posterior wall is split by the posterior limb or the posterior column portion of this fracture. So most likely it's a transverse. Okay, it's just a transverse fracture, sort of cleaves the joint into 2 halves. And then I'll give you another look there at the femur. I gave you time just to study these, but you know the topic is impaction, and so I'm not going to really get onto that femur too much, but I'll give Dr. Dunbar a little bit of chance to talk about it since we're doing femur day a little bit today, yeah?
Yeah.
It's just it's planned. And so I want you to be able to see the impaction area. Who's got the mic? You pass it to someone that hasn't spoken yet. Do you see the impaction area? What's your name? How you doing? Is it on? Yeah. Say 1, 2, 3.
1, 2.
Yeah, it's
There
on.
you go. Now it's working. Yeah, I'm Curtis. So I see some in action, but superiorly.
Yeah, so we can see this right. You see how it's just preferentially dense in the cancellous bone. When you look for impaction segments that are discrete, you'd like to just see chondrocancellous crush without a cortical yield. And so this is a really good example of chondrocancellous crush, a fragment that you can see is pretty distinct without a cortical yield. So we know that head most likely caused some crush, and then the transverse yielded, and then that head did maybe some more crush, and the head probably displaced maybe through the fracture. We don't really know. And then if you look at the coronals, you can see it's pretty much straight cranial. You see it? See where it's at? Yeah. Okay, so we have to decide what to do. I hate to tell you, but it's a Friday night. It's around 8 o'clock. And Avery, I think it's your turn. You're on call with Dr. Aker. And this is going to come to you really fast. And what you think y'all are going to do? You want to call JD and get him to come help you, or you're going to let him alone? Teach you to turn it or hold. How do you hold it? You're going to work on Friday night, or you're going to wait till Saturday morning? Pass it off to Dr. Munns. Okay. Well, you can stay on. We'll let you stay. We don't send you home if you want to stay. Dr. Dunbar, why don't you take the mic and tell what you think ought to be done for that femur? 8 o'clock at night.
Well, it's right there.
It says lapel.
The first thing if the patient's awake, we want to have a little bit of a conversation before we get started.
He's
The
awake.
Signs and symptoms or signs on that image that are may predispose to a not optimal, right? So
Just maybe give me 2 examples of what you're looking at. What do you think that are pretty terrible?
the amount of comminution
Yeah.
immediately,
Yeah.
the amount of comminution in general, the fact that it's not just the neck, it looks like it's peripheral.
Yeah, all through the trochanter.
Plus
Yeah.
Subtrophic extension, but posteriorly as well, the amount of comminution posteriorly is a particularly good predictor for outcome. At least you have a spike anteriorly that might offer you a reduction aid. In an older patient, boy, that would be a hard arthroplasty for me, since I don't do it at all. But like I think a 26-year-old, I'm going to fix this, but in the absence of a read medially, this is an implant that's going to struggle and may need secondary procedures.
What do you want to use?
All
All night long or tomorrow morning? Pass it off to Dr.
Why
Beingasman.
do you say that? Because Curtis and I did something not so different
All night
on
long.
the Friday evening of the fellows' graduation this past summer.
Good. What'd y'all do?
We actually had a shaft fracture as well.
What would you do for this?
So I would probably, you get 2 approaches. You get anterior midfield approach for the reduction and a lateral approach for the implant application, but also to get the trope right, I think. So I'd probably build from distally proximally, get the trope right, and then I'd probably try to get the neck fixed, and then I'd leave my implant low.
What implant do you like?
We use the FNS a fair amount now, but I'm not sure this is going to be up to it on its own. I think it would need either supplemental screws above it, but, having something near that medial cortex, I would have to look at this and see if I could figure out some way to have, I don't like having just a diving board with a deficiency medial. I like it.
Like this.
Pretzel bridge, you could do that.
Yeah, so this is what they did all night long. So this is 1 to 4 a.m. This is what they chose to do, and that was it. So my point is now the patient's alive, and I've got to deal with this thing. And so, any ideas what we do with that? Reza, any ideas what to do with this? You know this case? Yeah,
Yeah, so,
you know it?
No.
Okay.
so I would do a Milton approach. I think in this case, if they don't pick up, all for cleaning out that fracture, cleaning it, clamping it, and then, I think it'd be.
You like this clamp?
I love it.
Okay.
It's a good spot to put the.
Looks like a good plan. Okay.
And, if you mentioned where I put a thumb, pelvic region, this case, but that plan kind of right above it. And then, put an anterior column. And it looks like, look at the other views, usually that anterior column is spliced also randomly. And if I thought you didn't have a good bone quality, how old would you?
26 years old, and
Have good bone quality, so I don't think that.
we couldn't make this clamp work for at all. I put this thing on about 6 different places, and I couldn't get this thing to reduce at all. And finally, I just put a couple of drill holes, put a little tenaculum on the front, and went click, click, click. Yesterday, we talked about click, click, click. It just went click, click, click. And so then we went ahead and just put a couple of screws across it to hold it, took the clamp off. And then you see the circle. The circle shows the thing that we don't like to see in the operating room because we think we got the articular reduction really great, but that's an air arthrogram. And the air is trapped in the joint and it's reflecting the defect where the impaction segment is. And so that's right. That's an indicator that your joint is not good. So if you do an acetabulum and you see some air in the joint, it's down around the capsule, you're good. But if you see it up in the articular area, you're bad. You don't have it right. So we don't have it so good. So what I like to do is I just need more information. So this looks like we got the anterior column really, part of it really good. We probably put the clamp on a little bit too vigorously there on the quadrilateral surface and sort of cracked it a little bit, hurt a little bit. And we still got this impaction area that doesn't really block our reduction, but it's not right. And you can see where the air arthrogram is coming from. And so to make a long story short, I spent about 5 hours planning how to get to this thing. And about the only way I know to get to it without an extended iliofemoral operation is to make a osteotomy that gives me access to the articular piece. And so I planned and I planned and I planned and I planned and I planned because I needed an osteotomy that wouldn't hurt the normal part of the wall, but I needed an osteotomy that would give me a window big enough to see the impaction piece and to also do something with it so I could put it back where it came from. And so I would have probably really benefited by some type of printing. This was long before we had printing. But maybe that might have helped me to understand this and I could have planned the surgery a little bit better. But this is where I finally decided where my elliptical osteotomy needed to be in order to see where this was. So we turned him over and did a prone cochlear Langenbeck to try to access this and made, little drill holes into an osteotome and sort of try to get it fairly dense and pull this plug of bone out. And then when we turned it over, we found our treasure. So this thing is stuck on our osteotomy and everybody's happy right now because we've made the right decision, at least we think we have, to access this thing. Then I can just peel that cortical piece, that triangular cortical thing off with a bunch of cancellous bone behind it. Just leave the cortical shell. I don't really need the cortical shell that much, not yet. And then I can put it back through my access osteotomy. I'm looking right at the head. I can see exactly the shape. I can rotate it to where I know it goes. I can put it right on the head, right into where it needs to go, tamp it down, look at the C-arm, see that it's good. And then, I like grit, bone graft grit, and then pack the sand, and then put the cortical shell back on and And then if I want to, I can mess around with the posterior limb of the transverse also. It's right there in my visual field. So I can, if that needs tidying up, I can clamp that a little bit as well. And anyway, we have a nice, you can see we have a nice repair. It all kind of came back together. Good result. Yeah. Let's see if this works. I don't know how to do this stuff. Yeah, this guy is so talented. He walks on walls. Yeah. So I don't know if you guys have taught your patients how to walk on walls. This is a video Dr. Aker took in the clinic of him at his 3-year anniversary, and he's real good. But I'm sorry, I don't know how to make all that jazzy stuff for you. This is his film at 3 years, and he was doing all the things that people do when they do it. So the summary is make sure you can recognize impaction, understand, especially when it's in the dome. This is the weight bearing area. That's pretty high value property. Almost all of us in this room, not all of us in this room. My dome is not high value property like it used to be. Dr. Crutch is right here. He can help me out. But for y'all, your dome is pretty high value property, and you'd like to stay on your native hip as long as you can. And then you can also see, despite all of the angst and concern about the comminution and things like that, his blade has survived. He's made it, and he's had an uneventful union of his complicated right femur operation as well. You have any questions about that? Sort of impaction is not uncommon. That zone is uncommon, and then making an access osteotomy is uncommon. But these are the things you have to do in your career, and no one teaches you this, but sometimes you have to. You don't want to be crazy. I mean, we don't want to confuse crazy with innovation, but you want to stay with sound principles. And what do you think, Avery, was the key to the success of the whole thing? The planning. And so I like the result of the congruent joint, but I can't get there if I make a problem or don't do the proper osteotomy or don't get that thing right. But again, I think maybe 3D printing in today's age might have had a real role. Remove the femur and see exactly, then you could actually do the osteotomy on a model before you did it on the patient. I think these are maybe the things where simulation and printing are going to help. How much time do I have? Okay, I'm going to scoot a little bit. Here we go. We've got a polytraumatized female in a car wreck. She's obtunded. Her thigh on the right's deformed. Her lower extremity is deformed. She's got a bumped brain that the neurosurgeons are pretty concerned about, but not terribly concerned. But they're not real happy with us doing a whole bunch, at least not at this time. You can see she's got a condylar injury down there below that comminuted shaft. This is closed, and then she's got this fracture dislocation. Again, the two lines are disrupted here, but instead of that caudal segment displacing medially like it usually does, it looks like it went laterally. That's kind of unusual. And then she's, dislocated posteriorly. So she's going to get a full bunch of imaging. I'm going to get through these guys because I think they're pathetic, but we'll go to the surface renderings, and gosh, it looks like she's got that same anterior column limb, just like the last guy. Hers is not very displaced, but it's in that same fault line, right in the psoas gutter, just like the last guy. And then if we roll her around, we can see her transverse tracks through the quadrilateral surface and through the ischial spine. This is just almost just like, you almost think, well, wait, this is the same guy, but see her femur's good on the right there, at least the upper part of it. And then you can see she's got a posterior wall. And the last guy didn't have that. And the posterior wall's right in front of the head. You see that? Right in front of the head. What do you do with this when you're on call? I do too. But I want to be thin and young too. And I don't have a time machine. I love pie, so that I'm in trouble. What about you? If it's your hip, you want me to pull on your hip? You want to just traction it, okay? You want any consult? You want to? Who's got the mic right there? No, don't take the mic. You keep the mic. Tell me your name again, please. Brian what?
Brian Vasquez.
Brian Vasquez. Okay, Dr. Vasquez, what should we do? For me or for everybody?
I think what I would want for me and what I would do for somebody else. Production.
Just straight to the OR. She can't do that if she's got this brain thing and the neurosurgeons are going,
If I put the left side.
No manipulative reduction. You don't even want to try.
I mean,
My old friend Lyle Lovett has a good song, and he said, "What would you be if you didn't even try?"
I'd be concerned about, further displacing and incarcerating the posterior wall fragment.
Is that gonna, is that a problem? Okay, so this is not a problem, that would be a problem, to further incarcerate it. Well, our residents aren't like you. They're just gonna pull on stuff, and so now they pulled on stuff, and now they made it worse.
Yes.
That's worse. That's worse than that. Tell me why. I'm just curious why.
I mean, I think it makes elements of your final murder, but to their credit, it does, I think, make the situation sad.
That's gonna make them feel bad. They're gonna have to go to a safe spot. What do I tell them? God dang it, you shouldn't have done that. What do I tell them? I tell them, good try. I like what you did. It was a good try and you almost got around it. And then they went ahead and got another brain CT. As long as they had a brain CT, they spun down and just tagged her pelvis. And so we can see what it was and now what it is. And so now we can get a really good look, not just the plain film, we can see where that fracture fragment is. Don't you see? This helps me a whole lot. This helps me a whole lot. And then I can see where we are with the fragment. Now I can see exactly where it is and where the head is. So now instead of being posterior, it's almost like the head's almost anterior, isn't it? Can't quite get out. God bless you. Was that a sneeze? That was good. All right. So we have obstructing fracture fragments, and these are, you use the term incarcerated. A lot of people do that, or not congruent or not reduced, whatever, what do you want to say. But the neurosurgeons have now allowed us, they told my friend Dr. Munns, he can nail her femur as long as he doesn't lose a bunch of blood and doesn't waste a bunch of time, and he's quick. And then they told me I could do something for 30 minutes. And so you probably know what I'm going to do, don't you? You know what I'm going to do? Dr. Clavino knows what I'm going to do. I'm going to just ask Dr. Munns if he'll let me just put her supine right before he nails her femur. And if he'll let me just square off her flank. And if he'll let me just sort of find where her joint is. And if he'll let me, this is a patient that's prone, I'm just showing you where I would make the incision relative to a cochlear back. The yellow stripe is where I'm going to make the incision. This is actually her hip a couple of days later when we were going after acetabulum. You can see where the staples are. That's where I worked. And all I did was I just made a wound, and then I made a blunt dissection down to the back part of her hip with this right angle clamp. And then I went right where that red circle is, but not where that yellow line is. And so I went into this defect to where she had exploded only hours earlier. And I just put this clamp with the fluoro and got it in a good position, checked it on a bunch of views on the oblique views. And then I had, I pulled some traction on the leg, just some manual traction on the leg, and then just flipped it out. It's a big piece. It's a great big, this is a technique that works for great big pieces, not little bitty things, but it helps us now. Takes about 15 minutes, and then we can just settle her head right back into her dome, right where you wanted it to go. And then Dr. Munns can take over and do her femur. And then on Monday, I can come back and then turn her over and then do her acetabulum. And now her head injuries, all kind of resolved. She's had 3 or 4 days for them to sort things out. So we don't want to be upset about obstructing things. We don't want to be upset about people being somewhat proactive about doing manipulations. Sometimes they can slip it around the wall and it just all works out. Sometimes it obstructs. And if it does obstruct and it's a big fragment and we can sneak them to the operating room, we can do a little disengagement and move it on out. Yeah. But if it doesn't move on out, then we have to do an open reduction. Yeah. Okay. So again, not a uncommon problem. We see fragments of the posterior wall getting brought into the joint all the time. But again, this is great solution for a big fragment, not a small fragment. Yeah. Yes, sir. I'm going to have to leave her in traction until they tell me that it's safe for me to put her prone for about 3 hours. I need about 3 hours prone to do that. I don't have another, I'm happy for someone else to tell me another solution, but rolling in an arthroscopy tower is not something that, as you know, but hanging out with us is not something that a bunch of us do, and would almost be like Curly Moe and Larry mucking around the hip. I mean, maybe that's a skill I should have. Yes, Bob.
There are reports of Donald Parkinson. That's
Yeah, Dr. Helfet had a famous report of a patient. They tried to scope a hip with an acetabular fracture and things didn't go well, but he could do a dry scope. Could do a dry scope or at least try. That's about the only thing I could think of is if I had that skill, maybe I might try that. I don't think I can do that in 30 minutes. So this took about 8 minutes. This took longer to prep and drape than it did to flip it out. Okay. Everybody likes elders, and I do too, because I am one now. And so I have a great passion for this population of patients. I actually told Dr. Wagner this morning that I hadn't fallen yet. And so that's sort of how I'm going through life right now. I haven't fallen yet. This lady fell, unfortunately. You can see she had a common problem. She was seen by a doctor and she had an uneventful cephalomedullary nailing. She had uneventful union, and she made it to 2 years later when she was involved in an automobile accident. She didn't have any pelvic instability, but do you see her left pubic ramus fracture? Yeah. She's very active. She's a retired nurse. She and her husband are active cyclists. They bike and hike all over the place. She's having some trouble with that now. And then she was treated without surgery. Here's her inlet and outlet imaging. 3 months later, she's really starting to hurt worse. She's starting to try to do more, but she's hurting worse. And her doctor gets a CT scan, and it looks like the posterior ring is real good, and the anterior ring is a little bit slow to heal. You can see on the coronal, he's got a little deformity. But she limps around and tries to deal with it, and they sort of nurse her along. They check all her labs. They make sure she's on vitamin D. They give her some yogurt every day. She's on all these different things, and her bone health has been optimized. You know, because she had the right femur fracture. She kind of got bone health optimized then, but then they thought, holy cow, you're not healing your ramus. So they rechecked, and she was pretty much optimized. So from a medical standpoint and all these things we do, she's pretty much where she's at. So this is her now a year after, and she came to see me, and she's can't do anything now. She walks around. She has to use a cane. She and her husband can't do any of the things that they like to do. And she has nothing but left groin pain. And so you can kind of see what's coming, because we talked about it yesterday, a little bit about the ramus non-union. Doesn't happen very often. And a lot of times, even when you see it, we learned yesterday, or at least we said yesterday, I'm not sure you learned it, but we said yesterday that you see it all the time and they're asymptomatic. And so we don't make a big deal of it because we know it's like a stiff bubblegum fibrous union, or it's a chondral union that just hadn't been mineralized, or whatever it is. But in her case, that's not it, because she's just not getting comfortable. So we know that she's got a symptomatic non-union. And so this is what her repeat CT looks like. If you remember, there were two components to the fracture. There was a medial component, and then there was a more peripheral or lateral component. Looks like the medial component consolidated, but the lateral one didn't. Now, and we have these surface renderings to show the superior and inferior. She has no pain on her inferior ramus. You can palpate her inferior ramus. She doesn't hurt. It's all in her inguinal area, and she can put her finger right on where it hurts. And when you watch her walk, it's clear she's not good. We can roll the image around here and just see what's going on, and we can get multiple views and see this non-union. And I think y'all probably know where this is going to go. What should I do? JD, tell me, what should I do? This is like a sports injury, bro. It is. Well, I mean, she's like an athlete. Let's just pretend. I mean, she is an athlete. Let's say she's in the elite senior Olympics. She competes in cycling, and she's Lancet Armstrong of the senior circle. Clean it, clamp it. So clean it, clamp it. See it, clean it, clamp it. Well, yeah, we have to do something, because we're like the end station on the train. You know how the train stops and turns around? That's my clinic. Yeah, I mean, I'm in here where the trucks take the trash and just dump it. That's me. I'm the dump. happy in the dump. It's going to be kind of a weirdo plate. What kind of approach you going to use to plate that? It's going to have to be a bumpy plate, humpy plate.
Yeah.
You know, are we going to put one on like top of the ramus or behind the ramus or under the ramus? Where do you want to put it? Because it seemed like when you do that, you're going to disturb the blood flow, you know, as well. But you want to compress it because you think it's hypertrophic, or is it atrophic or oligotrophic, or do we even use that term? Do we even go through? Is it hyper? Is it oligo? Or is it A? What is it, Kevin? Which one? So it looks like she's got some periosteal new bone formation here, and maybe some junk over here, but just not quite getting there. And so usually what do we do when we have those types of situations? What stability is usually our friend in that, okay? And so we're going to clean it, clamp it, and that's where we get our stability from. But then we have to exchange the clamp for something, and we have to have the clamp in a position where it doesn't obstruct the surface implant that you're trying to use. Okay? Can we put a ramus screw in something that's not like a Venn diagram? You know, like whenever we do medullary screws, we sort of, it's like a femur. We have to have the canals at least somewhat overlapped, you know?
Yeah, I think that would be challenging.
Okay. You want to call a consult? Who do you want to call? How you doing? Welcome to the dump. It's me and you, and I'm in Seattle giving a dadgum lecture. So just take me past what he said then. Thanks for agreeing, and just take me into, let's just treat it. JD just fell out. He's got the vapors, and he's got a ticophobia. He's not coming to the operating room. Like an intrapelvic plate. Maybe even go over to the other side of the pubis, just sort of spanning on over to the right pubis. It'll be pretty limited over here. It's kind of looked like a jump zone. Dr. DeBray yesterday taught us about bone that just, I think he called it trashy bone. We're on a trash dump theme right now. Okay, she didn't think that sounded like a very good idea at all. She thought that sounded really aggressive, and we went with that just needs stability theme. And so we just put her supine and put a drill across it. This is just a 3-5 drill, and we use a sleeve and just sort of make a canal, and then it's kind of obstructed, so we've got to get across it, just like some femur canals. You got to make the canal again. You got to make a place for it to go. And then you can see we went on the far side, and then we used just, looks kind of narrow and kind of funky, but we just used a 4-5 cortical screw. And then lo and behold, I went to the Benershka school of filling things up. And I've seen Steve's with his K-wires, and so I like to do the same thing with screws. And so I believe filling up a can with screws that's shaken around and compress it a little bit is probably pretty good. And as you might imagine, she had immediate comfort in the recovery room. Even though we had made a stab wound and I put some numbing medicine in the stab wound, her pain, she said, she stood up in the recovery room and said, that's it, which is kind of cool. But now we've got to get it to heal because the screws are only going to hang on for so long, right? So it seems like we've done the right thing because she's got stability. Now she's got comfort. And I followed her for about 3 months and she kind of went away. And then I saw in the record that she was having a bladder procedure about 3 years later. And this was the bladder procedure fluoro. So you can see the consolidation of it. Again, you realize now I'm a PACS stalker. You may, maybe y'all noticed that after yesterday. I'm like always looking at the PACS, trying to find out what my patients have had. And then 8 years later, she had some bowel issues and had another CT, and you can see the consolidation. So a good solution for this problem. But again, you can see how corticated the canal is. And so we have to spend a little time with the drill making that canal access so that we can have a pathway. Take our time, clean the drill, cool the drill, stuff like that. Yeah. Do you have questions about that?
Of course, you brought up the idea of we had been instructed to be very aggressive.
She didn't even want to talk about that. She said she'd rather limp than have that. Or, I just said, well, what if this fails? She said, well, then we'll talk about it later on. Let's just do something simple. She just said, is there something simple? And I said, well, yeah, we just stabilize it or try. Same thing happened with this lady. She's a nurse. She shows these Bouviers, these world champion Bouviers, and she likes to ride horses. A gait kind of got after her, but she's got groin, like pain in her inferior area as well. And this has been going on for a couple of years now. And she's pretty incapacitated. She has a tough time working as a nurse. She's an RN, and she can't do the dog shows anymore, and she can't ride her horse anymore. And so I did this case with Dr. Munz when he was a fellow here. She came up from California, and we did a similar thing. We went integrate on her with just a single lag screw, but her inferior ramus, as you can see, was also identifiable, and she was really sore there as well. She reported pain there, so we put a medullary screw across this as well. And you say, well, you didn't. That's not in the bone, but it is. Sometimes inferior ramus is pretty thin, and it's almost like an ellipse. It's really narrow, but hers was very competent for us to get a screw into, and we had really good imaging to where we could see it. Same type of thing. This was her 4-month result, and then I got an x-ray from her at 10 years. She had some other type of belly pain or something, and she just said, I thought you wanted to send it. I still get Christmas card from her every year. She's good. So far, so good. But again, I would say be careful, because some of these people might be a little crazy, but don't think that you have to realize, and any spine surgeon will tell you that pain will make people crazy. And so if you can solve their pain, then they may not be so crazy. Yeah. Yeah. Do we have time for a femur or no? This lady's had 3 operations, maybe 4. She thinks she's had 4. I think she's about 64, and her husband owns all of the concrete distribution of the country of Mexico. Just think about that for a minute. If you pour concrete in the country of Mexico, he gets a check. That sounds pretty good. I don't know how you get that gig. Anyway, she came up, and this is what she had. She brought these images, and you can see she's got a distal femoral non-union. And she's had a surgeon take away her plate. They thought maybe her plate was giving her symptoms. So she had a first surgery. It didn't work. They did a revision surgery. Then they thought the plate was bothering her. And she's had patellofemoral problems for maybe 30 years. She's had really bad patellofemoral problems, but this is a whole lot worse than that. You can see her patellofemoral joints. Dr. Crutcher, what's up with that? Don't you know all about this stuff? Do people tolerate that pretty well or not so good?
No, that'll get to the point where it's not talking.
Okay, so we've got this double problem here, because we've got this bone that didn't heal, and then we've got this patellofemoral stuff that's driving her nuts. And so does she need to have her distal femur replaced, Dr. Crutcher?
That's an option.
Should we do it?
I can't tell you how easy that is to fix. Straighten out, it's correct that now. Get a little bit more anatomic. It might make your future knee replacement better, but if you can't do it, then you go to a different.
Dr. Clavino, your solution for this patient? I don't have a microphone.
Yeah, I'll talk about it. So
Okay.
I don't.
He's got one.
I don't do any total knees, but my understanding is anytime you can make total knee easier, that is the benefit to the arthroplasty surgeon. So I plan to correct the malunion first and try to set her up, assuming she would get symptomatic from the arthritis, that at least she could get a more straightforward knee arthroplasty.
She said she's never had any infection, no fevers, never dripped, none of that stuff. Dr. Cannon, is this in your wheelhouse? You want to take the mic and just tell us what you do for this lady? I would encourage you to do a great job, because there may be a donation. The Cannon Endowment might come to Swedish Hospital if you'll just treat her right. Or if you don't, you might get a visit by some friends. They know where you live. Don't worry, they're really nice.
This is a trauma talk, so I assume you.
No. This is to talk about the distal femur problem. So this is femur day, and so I'm just, I'm here to make this educational moment relevant to, everyone in 2024.
Well, I can't see my hands. This would be a different femoral replacement.
It would,
That's what I do.
and how would she do? Just tell us, would you have difficulty with the procedure? Would there be a difficulty with the procedure, or is it pretty straightforward?
It's a pretty straightforward procedure.
Okay, and when she, how she, and sort of, we know her patellofemoral symptoms are gonna get better. And we know her non-union symptoms could be better. What would she complain about in a year?
Actually, I don't think she would complain about things.
Be good.
The problem is if something goes wrong, if it gets infected,
Okay.
if it loosens, something like that. So,
So that's the, or periprosthetic fracture.
yeah, so I think it's got long-term issues. She was 60 something.
She's active too, yeah.
Yeah, so I think she would cover well and she'd do well. I think even for even with sedentary lifestyle, she would be fine with that. But going 62 and with another 30 years, losing all those, arthroplasty complications. So I think it could be fixed better and instead of for more connection.
Would you hand the mic to Dr. Banershka and let's get his thoughts? Dr. Banershka, you've treated hundreds and maybe thousands of non-unions. What do we do for her? She's as nice as you can imagine.
Well, I'm glad I'm not her, because you all are gonna have to figure out, and quality of bone. Ramping up around. Quote, and the big problem is for a lot of people that is what included is that she's got not great bone, maybe from surgeon bone, like.
Well, it's been hurting. She can't really do, I mean, her other femur looks great.
That's the question, whether she just wants to be able to walk and her terminal pivotal joint's not horrible. But I don't try to feel
Do we even talk about a ring fixator?
I had a patient on Wednesday said, you are never going to touch me with one of those.
What would Dr. Brinker say? He would probably say do a friend. Anybody for rings? No? Reza, no rings? No ring.
Chip, but before you go, the interesting thing is patterns, right? Because I agree with Steve that her bone is poor. So if we were going to realign that, I mean, one good principle is pull on good bone and push on bad bone, right? So she would probably benefit most from a medial implant rather than a lateral.
Steve, what implant would you use to stabilize her?
I-
Say it again? A blade plate.
Maybe a
Yes. Yeah, we, hold on. We just, took her to the operating room and cleaned this out. We worked her up for infection. She didn't have any infection. We just cleaned out her non-union site. It looked pretty good when we got it all cleaned out and had pretty good bleeding. And then I just, put in a summation, drill, but I put it a little bit, not 95, but a little bit 90. And then put in a seating chisel after, pulling out some bone, and then inserted the blade and then held the blade. I know a lot of people think you don't need to do this, but this was a screw for me. Maybe I didn't need it for her, but it just made me feel like I had the distal part. And then you can use the articulated tensioning device on a patient like this to further compress it. Now it's going to make her a little short, but we're trying to get the bone to heal. And this was a discussion that we had before the surgery, is that when we compress this, you're going to lose some length. And she had already lost some length as well. And if she was incredibly comfortable with a shoe lift, if you just made her femur stop hurting, at least that's what she thought. And then we used the DC holes. We did two, we sort of double DC'd her, and then added interfragmentary lag screw, and then added some of the stuff that we pulled out. We sort of packed into the little defects that were left. And then that was her result. after the surgery and the post-op, and then she went on back to Mexico. Her doctor followed her there, and she had uneventful union. She started on the swimming program. She still was protected weight bearing. She had gotten used to using a walker, so she was able to just do range of motion, but she did progressive partial after about 6 weeks, and then was full weight bearing at 4 months. She still had patellofemoral symptoms. Those didn't go away, unfortunately. Maybe she should have had the distal femoral, but if she needs that at some point, she has a united. So a nice result. But again, staying with the principles, using not necessarily fancy implants, but just old implants that work. But again, the principles of making sure it's not infected, debriding, compressing, and then knowing how to use the plate and the articulated tensioning device to get it to do what you want it to do. Yes, sir.
So one thing comes to all that face that better stockpile plates because they don't want to make them anymore because they're cheap. They don't cost much. You look at a typical box plate versus this doesn't cost anything, and we would customize these with the chip to make it draw. We would make a hole in the end of the blade and put a screw that would go through the blade so that it would actually flat it. So it would capture that triangle bone. But they don't want you to use that. They want you to use something fancy that costs 10 times more.
So you can make that screw aim different as long as you roll this hole a little bit,
That,
and then you can put a hole
I
in
had
there.
to figure out how to do because there weren't a lot of people. So we had to make something that would work like that, like wood, that's the building. And unfortunately now you're going to keep problems with petition bone.
Okay. Yes, sir.
Curious for our plastic surgeon, it's kind of based on where this is now. We haven't been corrected. Would this still be a DFR or would this be a total knee?
So I did a great job of straightening out this femur. It's nearly anatomic. She still has significant patellofemoral symptoms. A patellofemoral arthroplasty is not out of the question.
I see.
She is at a little bit of an improved prognosis for that because she has a little bit of patella and will need to do better with a isolated PFA. And if she developed fractional PFA down the road, we have technology that might allow us to do a total knee person without looking out any of that hardware.
Any comments? Okay. I exceeded my time limit. I'm very sorry, but I felt compelled to show a femur since it's femur day. So I thank you all very much. You didn't miss anything by not talking about controversies. I think these are controversial enough and more coming. Thank you.